So hello students, I'm Dr. Cheshta Agarwal, your dermatology educator. Today we are starting with a very important series in dermatology and that is back to clinic. So we are here in the clinical setups. We will be discussing the different case scenarios, how to approach those particular diseases, what are the different examinations which you have to do, how to take a proper history, and that we will be discussing in this new series of back to clinic. So welcome all of you. Today we have a case of leprosy and today I will teach you how to approach a patient of leprosy. So let's start. Leprosy patients come to us with mainly two complaints. One is presence of red or hypopigmented plaques. Second, the associated loss of sensation. So whenever you see a patient with loss of sensation, and the plaque which is either red in color or hypopigmented, you have to think of leprosy. Now, what should be your approach? You have thought leprosy in your mind, but you have to prove it, right? Whether the lesion is actually hypoaesthetic or anesthetic or not. So for that, how to examine a patient of leprosy? Please remember, we have two modalities. We have two things which we have to see in a patient of leprosy. First is you have to examine that plaque. You have to look for the shape of the plaque, the margins of the plaque. What is the status of the outer margin, whether it is perpendicular, whether it is sloping? What is the status of inner margin, whether it is perpendicular, whether it is sloping? First, so what does that plaque look like? Second, you have to look for number of plaques. How many plaques the patient has? Whether it is few plaque, less than 1.5 or less than 1 or 1 to 5, or it is multiple. If you have multiple plaques, it is our approach or it is our thing to see whether it is a symmetrical, bilaterally symmetrical multiple plaques or it is more towards one part of the body. This will help you identify whether you are dealing with a localized tuberculoid leprosy or you are dealing with a widespread generalized lepromatous leprosy. So I will be telling you what are the different features with respect to the different pole. But always remember that in your examination, the first thing which you will do is you will examine that plaque in terms of number, in terms of shape, in terms of symmetry. After examining the plaque, the next thing is you have to look for the nerve. What is the status of the nerve? How many nerves are thickened in the patient's body? We always examine the nerves of upper limb, lower limb, and face because these are the most peripheral nerves, cooler nerves, and they are more prone for damage in the leprosy patient. So that is the second thing which you have to all notice. The next is you look for the sensation, whether the area supplied by that particular nerve, whether you have nerve damage or not, that you will see by the sensation of that particular nerve or the motor function of the nerve. Today we have a patient with us and we will try to examine all these nerves in that patient. Let's start discussing with the morphology of the lesion. So coming to the examination part. First of all, remember all my students that whenever you examine a patient of leprosy, you have to ask the patient to sit on a stool where majority of the body is exposed. So like this, you can see that here we have asked the patient to sit on the stool and the body is exposed so that you can examine the whole area of the patient's body. Second, always examine the patient in the natural light. Always examine him under the natural light so that you can see the color of the lesion. You can see the raised or depressed nature of the plaque. In artificial light, too much of artificial light, you may not able to examine the patient properly. So like that, the first thing is you have to ask the patient to sit like this. Okay. Now coming to the examination of plaque. It is very important to check for the following point. First, what is the number of the lesion? Whether it is few like of tuberculoid or whether it is multiple like that of lepromatous leprosy. How they are distributed on the body, unilateral, bilateral, symmetrical, asymmetrical, etc. This will help you give an idea about the type of or the pole of leprosy. Second is morphology, whether it is well defined, ill defined, whether it is sloping margins or perpendicular margins. Now just look at this image. This is a very classical patient of tuberculoid leprosy. Please remember, tuberculoid leprosy, the cell-mediated immunity of the patient is very strong. So the number of acid-fast bacilli is less, M. leprae is less, and that is why patient has a very localized type of disease. So you can see it here that the disease is localized, you have well-defined plaque. The outer borders are perpendicular and inner border is sloping like a cricket stadium. This classical perpendicular outer border and sloping inner margin indicates that disease is well defined. not progressing to the surrounding skin. This is your tuberculoid leprosy. So when you look at the patient, you will first examine the lesion, whether it is well defined or ill defined, whether it is sloping or not. You can see it here. This is a patient of borderline leprosy. If you closely examine this plaque, let me just tell you this. If you closely examine this plaque, you can see that outer margins are sloping. Initially, in tuberculoid pole, it is perpendicular, but now in borderline, it is sloping. This indicates that the disease is progressing now. This indicates that CMI is reducing and the number of organisms are increasing. So sloping outer margin, perpendicular inner margin, very classical inverted saucer shape appearance, which you see in the patient of borderline. The center is punched out, known as punched out appearance or Swiss cheese appearance. This is your borderline. While when you reach to the tuberculoid end, when you reach to the lepromatous end, in lepromatous end, CMI reduces to minimum, nil, and you can see patient develops diffuse infiltration, multiple bilateral symmetrical plaques all over the body. Let me just focus the third image here. You can see that bilaterally the patient's body is involved. So this is the symmetrical multiple lesions on the patient's body. That is what you mean by the asymmetry and symmetrical. So the first thing which you have to see in the patient is the number of lesions, the distributions, the arrangement, and the morphology. Next is you will look at the surface of the lesion. When a patient comes to you, you have to see what is the surface, whether it is smooth, whether it is dry. What is the significance of dry aesthetic patch? It indicates that a patient has loss of nerve function. When the nerve supply of sweat glands are lost, you will see dry aesthetic patches. So look at the nerve or look at the lesion. Next is the sensation. Very important, on that particular plaque, you have to check for the sensation. Cold sensation, warm sensation, that is temperature. Then you have to check for the pain sensation, and then you have to check for the touch sensation. Starting with the sensory examination in a leprosy patient. Now please remember, leprosy is a primary disease of peripheral nerves. I told you in the beginning of the today's session that leprosy, which occurs due to Mycobacterium leprae, which has 30 degrees centigrade optimum temperature for its growth. So it prefer the cooler areas of your body. One of them is skin, another is nerve. So nerves, especially the peripheral nerves, they are more prone to get damaged in the patients of leprosy. And that is why the sensory testing forms an integral part or an important part of leprosy examination. It is important for diagnosis because if there is no loss of sensation, if you have symmetrical plaques or asymmetrical plaque, other differential diagnosis becomes important. But loss of sensation becomes a very, very important part. And you have to check for the loss of sensation of skin lesions as well as the normal looking skin. What are the sensations we test? We test for temperature, pain, touch, and localization. The first sensation to go is always temperature because it is present on the periphery of the nerves. Temperature, you will take one hot and cold water containing test tubes. So what are the instruments? Let us first discuss what are the instruments which are used to, which are used in the testing of. Now, what are the things which you require for the examination of a patient of leprosy? First of all, you can see on the left side, these are your glass slides. This you have to examine, or this you need for examining the temperature sensation. Because in leprosy patient, it is very important for us to know whether there is loss of sensation, whether there is nerve damage or there is just nerve thickening with no damage, with normal function. So to check for the nerve damage, you first check for the temperature sensation, which you can see here is, there are two glass slides. We fill them with the water. One water, we warm it using a matchstick. So we are just warming that water. I'll tell you what are the temperatures required. And you will touch it on the different distributions of the nerve and you will check for the motor function loss or not. This is for your touch sensation. You need a cotton mask and this will give you an idea about the touch sensation. This is for the pain. So you will just pick the patient. You can either use a needle or you can just use the tip of this forceps to check for the pain sensation. And this is required to measure the girth of the muscles. If there is muscle wasting, you will see that there is asymmetrical difference in the girth of the muscles. The temperature. So first is hot and cold water in a test tube. Objects with different thermal conductivities. Hot, the temperature should be around 40 to 45 degrees centigrade. Cold, it is 5 to 10 degrees Celsius. Otherwise, pain pathway will get activated. And please remember, make sure that the tubes are dry. For pain sensation, we use a safety pin. We can use a broken hypodermic needle or we can use a broken stick. For touch, Wisp of cotton, tissue paper, feather, soft brushes, or very light touch of fingertips are used. Ask the patient to say yes whenever he feels it. Allow for thick skin on palm and sole. Sensitivity of skin in the forceps. So please remember, we will always try to prefer, the areas which are extensor, not the forces or not the flexures. Wait for some time. Ask the patient, just touch it, wait for some time, let the patient respond. Do not ask the questions whether you're feeling or not. Just let the patient to speak himself or herself. Avoid the hairy areas because sometimes it is difficult to perceive the sensation because of the increased amount of the hair. Use some Do not use some symmetry, because when you ask the patient, in a continuous susceptibility, what will happen, the patient will tend to answer the question like that. So always ask it in asymmetry, once on one arm, another on another arms, like that. Sensory localization, patient is asked to pinpoint the site of application of the stimulus. This is the sensory localization. If he is not able to do it, it means you will touch it here and patient will say that you have touched here. So this is the misreference if he is not able to do the sensory localization. It may be the early sign of hyperesthesia. The permissible limit on the hand is 1 centimeter, face is 2 centimeter, back is up to 7 centimeter. Always make sure that you ask the patient to close the eyes. The uninvolved to involved area. You first go to the uninvolved area because you have to tell the patient how he will feel. So first go to a normal skin and then go to the uninvolved skin. Give adequate interval to the patient. Let the patient, or give some adequate intervals to the patient. Irregular intervals should be given, and you should have a control stimulus for the patients. So now let us do a sensory examination in a normal patient. So now we have taken a glass test tube. We have two test tubes with us. One of the test tube contain the cold water and another test tube contain the hot water. Please make sure that the outside of the test tube should be dry before examining. Otherwise, it can give you a false interpretation of the loss of cold as well as the warm temperature sensation. First of all, we'll start with the cold temperature. This is a normal glass light with a little bit of cold temperature. Again, the same thing we will do. We'll ask the patient on the different areas. Close your eyes. Feel alright? अभी
हाँ 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 हाँ
on the other hand,
हाँ 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 हाँ.
so like that we will examine the same procedure for the lower limbs also and the face also, like we did the touch sensation. For the pain sensation, we will use a small safety pin, and on the similar areas of all the nerves, we will do the temperature sensation also. So first of all, you have to make the patient sit on a comfortable chair. And now we are testing for a touch. So I've taken here a cotton swab. I will touch it on the different areas of distribution of ulnar nerve, the radial nerve, the median nerve, or the musculocutaneous nerve, and I will ask for the loss of sensation or not. First of all, you have to ask the patient to close the eyes. Close your eyes. So we are touching on the different part. What I feel?
हाँ
अभी
हाँ
अभी
हाँ
अभी.
हाँ
So this is for the right limb. अभी.
हाँ
Now.
हाँ
Now.
हाँ
Now.
हाँ.
So you can see that on all we have checked for the distribution of the radial nerve, the median nerve, the musculocutaneous nerve, axillary nerve, and radial nerve. So like that, we have to examine for all the upper and the lower limbs, as well as we do the examination for the face also. This is your touch sensation. Now coming to the palpation of the nerve trunks. We will first start with the palpation of the upper limb nerves. In upper limb, the most commonly or most frequently involved nerves, they are the ulnar nerves at the level of the elbow and the median nerve at the level of wrist. So for measuring the for seeing the thickness of ulnar nerve, we roll this nerve against the humerus, the lower part of the humerus. So you can see we have asked the patient to sit down, and in a handshake manner, we are rolling it against the, against the epicondyle or against the epicondyles of the humerus bone. You can see that with the help of left hand, we are just checking for the thickening of the median nerve. Thickening of the ulnar nerve. This is your median nerve, which is checked at the level of wrist. You can see that it is present just medial to the tendon of palmaris longus muscle. We have made the tendon taut by asking the patient to flex against the resistance. And now we are palpating the median nerve just medial to it. For radial nerve, you have to ask or you have to roll your fingers at the humerus bone because you know that in the center it is bind or it is attached to the humerus bone in a spiral manner. This is the upper limb nerves. For the lower limb, this is your lateral popliteal nerve which are felt against the neck of the fibula. This is your posterior tibial nerve which is felt at a midpoint between the medial malleolus and the calcaneal tuberosity. Coming to the palpation of cutaneous nerve of the face, you see for the great auricular nerve which is crossing the sternocleidomastoid, it usually crosses at the upper third of the sternocleidomastoid. Then we have the supratrochlear and supraorbital nerve. Supraorbital is at medial 1/3 and 2/3 and just median to it you have supratrochlear. So this is supraorbital and this is your supratrochlear nerves. Then infratrochlear and infraorbital nerves on the lower part, you have to just roll the finger around the orbital cavity. The other cutaneous nerve which you see is supraclavicular, which is present along the medial, middle and the lateral part of the clavicle. Ulnar cutaneous nerve which is felt at the base of fifth metacarpal below the ulnar styloid process. The cutaneous nerve of the thigh starting 5 to 7 centimeter below the inguinal ligament, running vertically down on the inner thigh, middle anterolateral aspect of the thigh. Deep peroneal or anterior tibial nerve on the dorsum of foot lateral to the tendon of EHL. This is the image which shows the the cutaneous supply of the different nerves of the upper limb. You can see the area distribution of the different nerves. This is for the lower limb. So according to the nerve loss or according to the damage, you will see the loss of sensation on these particular areas. So these are just images. Now you can simply use a pin or a cotton or a temperature test tubes for measuring, but you do have some test or some monofilaments available, which is known as Siemens-Winstein monofilament. They used to measure both the diminishing and returning cutaneous sensation. These monofilaments, they are made up of fibers, nylon fiber of 612. Indefinite shelf life, you can calibrate them very, very precisely and they are all of equal length. So like that, you can see that we have different, the thickness of the needle changes for all these monofilament. You will touch it on the different position. If you see that even the fine, if even the fine sensations are not there, this monofilaments can easily help to detect. So like that, depending upon the strength, you will measure for the different areas. For the hand, it is the medial 1/3, medial 1, 2, 3.5 finger is by the median nerve. The lateral 1.5 is by ulnar nerve. While on the back, it is the radial nerve on the medial side. Similarly, on the foot, we have posterior tibial, deep peroneal, and the plantar nerves. How to diagnose sensory impairment? For any tested nerve, you have to check whether there is loss of sensation on the distribution of more than one nerves or so. There are other tools also which are used nowadays, and that is the battery operated small device for nerve conduction studies. But we mainly try to limit our use till either the monofilaments or on the OPD basis, we can do it with the help of cotton swab or the pin or the test tubes. Now coming to the motor function of the nerves. We are done with sensation, we are done with nerve thickening. Now coming to the motor function of the nerve. First of all, in the motor function, you have to look for the loss of function of that particular area where that nerve is supplying. And second, you have to quantify it, that what is the grade of motor dysfunction. The three areas which usually examined, they are face, upper limb and lower limb. Now we will examine these small muscles of the hand which are supplied by the ulnar nerve by doing some tests. First of all, you will examine the palmoplantar skin, whether there is any atrophy, thinning of the hypothenar or thenar muscles for the ulnar nerve. Second is we'll do a card test. We'll take a small card and we'll ask the patient to keep it in between their two fingers. Now please remember your palmar interosseous, there are two types. The palmar interosseous and dorsal interosseous. There are two types of interossea. Palmar interosseous has an adduction function while dorsal interossea has an abduction function. The adduction function of the palmar interossea is checked by the card test. I will demonstrate how to do the card test. The second test is the patient will complain of difficulty in fanning if there is the dorsal interossea defect. The third is you can check for lumbricals. This is the function of lumbricals, the flexion at the metacarpophalangeal joint and extension at the interphalangeal joint. Patient in claw hand will have exactly opposite function, the extension at metacarpophalangeal and flexion at interphalangeal joint. This is known as the claw hand. Then Fremont book test, it is done for adductor muscle, adductor pollicis. Patient has to do the function like this, but instead there is flexion which occurs at the interphalangeal joint. This is your Fremont book test. Next is your median nerve. You look for the wasting adithina. You do a test which is known as pen touch to check for the adductor pollicis brevis. You keep a pen here and you ask the patient to touch the pen with the help of thumb. Now, next is you ask the patient to stabilize the hand and you ask the patient to touch the thumb to all the fingers. This is for opponent's pollicis brevis. You can ask for the lumbricals, the first two lumbricals, the clawing, and Ochsner's clasping finger test. If there is difficulty in flexor digitorum superficialis, the two fingers will be pointing. The flexion at the flexor digitorum superficialis will be difficult. So that is for the median nerve. Ulnar nerve, you ask the patient to extend the wrist against the resistance. Anterior tibial nerve or deep peroneal nerve, dorsiflexion of the foot against the resistance. Inversion of the foot becomes, you have to ask the patient to invert the foot against the resistance. For posterior tibial nerve, you have to ask the patient to plantar flex against the resistance. So these are some of the nerves tests which are done, or the motor function tests which you do in the patients of leprosy. Now we are doing the test to look for the motor functions of the hands, the motor loss of the nerves like ulnar nerve, median nerve and radial nerve. Now first of all, we'll make the patient sit relaxed. We are first doing the card test. We'll take a card, it is a thin card. Now card test is done to check for the power of the small muscles, and that is interosseous. The palmar interosseous has a role of adduction and dorsal interosseous has a role of abduction. So I will keep this card in in between the two fingers so that my palmar interosseous are working. I will ask the patient to do the same. Now I will try to pull it. So you can see that I'm trying to pull it, but the patient is able to hold it. This means the adduction function at the lower level, at the hand levels, the palmar interosseous, it is well for this particular functions, for this particular patient. Second is the book test. So we will take a book test here. Now, this is a test which is done for adductors of the thumb. You can see that this is working very well. If you see that the patient is changing it like this, the patient is flexing at the spaces of the fingers here like this. This means your muscle of the adductor muscles of the hand are not good. Next is your pen test. How do we do a pen test? I will take the pen like this and I will ask the patient to touch the thumb on the tip of the pen. You can see that the patient is easily able to touch the thumb. This is the pen test. And the next is you have to do for the opponents. Can you do like this? You can see that the patient can easily move or touch or have a function of opponents. So you have seen how we will examine a patient of leprosy. If he comes to us, what are the different areas you have to examine? For example, you have to examine the whole skin of the patient by making the patient sit, in a natural light with the exposed body part. Second, you have seen that how you will examine the nerve of these patients. You will first examine for the thickened nerves, then you will look for the sensory system and then the motor dysfunction of the nerve. So please remember, this is a very simple way to examine the patients of leprosy, and this is very important for us to examine so that you can determine the pole of the patient. I hope this new approach of the clinical discussions of the cases is helpful for you. Thank you all of you and have a nice day.